Welcome to Doc Talk, your go-to podcast for exploring the dynamic field of clinical emergency medicine. Each episode, we delve into real case scenarios that challenge and inspire medical providers just like you. From mastering point-of-care ultrasound to excelling in airway management and ultrasound-guided regional anesthesia. Our discussions aim not only to inform, but also transform your clinical practice. But there's more. We invite you to take your learning further with our hands-on educational courses, designed to equip you with the confidence and skills necessary to handle any emergency situation. Join us on this exciting journey of professional growth. Your next significant clinical breakthrough begins right here.
So shut up, sit down, start listening. This will change your life.
Hi, we're going to talk about awake flexible endoscopic intubation. This is something that in emergency medicine we don't do all that often, and that's why we need to practice doing it. Most emergency physicians probably don't practice this, and they just don't consider it part of their practice. They kind of work around it, but when it's needed, it's really valuable. The indications for intubating someone wide awake and in an upright position are really anything that distorts the upper airway, that makes you think, hey, when I go in there with a laryngoscope, maybe I'm not going to see the airway. And when you see a patient and you think, gosh, maybe a surgical airway is going to be the only way I can get this, that's a good time to do awake endoscopic intubation, because if you fail at awake endoscopic intubation, for the most part, you haven't burned any bridges. You can do everything else that that you would have normally done had you not tried the awake intubation first. A lot of the patients who need this are very cooperative because they're scared because their airway's narrow or distorted or something. So you have to pick the right patients. You certainly can't do this on everybody. Patients really need to be pretty cooperative to allow this. This is the kind of patient that, if someone's jaw is wired shut, you might want to just cut the wires. But certainly if their head is stuck in that position and they're really kyphotic and they can't move their neck, there's no other way to intubate that patient on the left there if he's stuck in that position than fiberoptic. An LMA might get into his mouth, but even that's going to be very tough. So this is a patient with epiglottitis. You'll see it here in a second. This is why you want to learn how to do awake intubation, is because there's the epiglottis. It's just this big lump. And you can see this is a video laryngoscope, and they work at it here for a minute, and they really never get a view of the cords. They don't seem to be in a big hurry, and that's because this person's already intubated nasally. So they're nasally intubated, sitting upright, wide awake, and then this is the look at the airway that they would have experienced had they, you can push RSI meds on this person, and maybe you'll get it, maybe you won't, maybe you'll end up doing a surgical airway. But why do that when you can just awake intubate them? And if you learn how to do this right, it's very easy. And the way to get good at it is to practice on yourself and your buddies. Like I said, most people in emergency medicine just kind of punt on this, and they think about it theoretically, but they never really learn how to actually do it. And that's because you don't see enough patients who need this to actually really get good at it. Before the disposable scopes came along, it was pretty hard to practice on even a mannequin or, anything. But now that we have disposable scopes that are only a couple $100 each, it's reasonable to get together with friends, or workmates, whatever, and practice on each other. It's all in the prep. If you can get someone anesthetized well enough topically, you can get a tube through their mouth or their nose down to their carina. And if you do it right, they can't feel any of it.
And I think you're going to find, when you look online, right, or go to YouTube, different websites, there's 100 different ways to topicalize someone. Yeah. And you'll go to airway conferences and people say, oh, just nebulize lidocaine and it will just numb up the airway and everything will be perfect. And really the best way to test those things out is to practice on each other.
Yeah, the way we came up with this method that we're going to show here is that I challenged our faculty to each prep themselves like they thought was the optimal way, and then try to intubate themselves. And it was quite a mess. 11 people showed up. They were all in terrible agony. Only 2 out of the 11 actually got intubated. The other ones were crying, bleeding. swearing, saying they'd never do it, something this stupid again. And that's all because they weren't doing it right. And that day, none of us knew how to do this method exactly what we're going to show. So the next year we did it again. Only 9 people showed up, and everybody got intubated, and nobody said it was severely painful. And some few people said it was mildly painful. No one thought it was awful.
Did they self-prep on the second year, the 9?
We all prepped exactly the same.
Yeah.
We didn't give anyone any wiggle.
So you had this method down by the second year.
It was kind of invented in the process
Yeah.
of that day. So, and it all comes down to using lidocaine ointment in your nose, which we'll talk about, or on your tongue. Lidocaine ointment is the stuff that you put on your skin, on a kid's skin, before you put an IV in. 4% ointment, not gel. Gel doesn't work at all.
But I think the key there is, like, if you think you're just going to go into a room, you're going to watch a video on what people do, and they talk about nebulizing. Firstly, if they're saying you nebulize lidocaine, you're going to have great success with this. Move on to the next video. That is not a good way to do this. I'm sure someone has had it work somewhere at some point in time, but that just move on. It's not how you do this. That's not how you do this well. Practicing ahead of time, getting used to topicalizing the patient, that's the key, and then getting used to the manipulations that you need to do with the scope.
Most people don't do topicalization optimally. They make up for it by sedating the patient. And you're trying. The whole point is to keep them wide awake. And once you start sedating them, you don't know what's.
Or they wrestle the patient.
Or they wrestle with them, which is not cool either. But so the reason this is all possible is because these disposable things. If we don't like to use an adult scope, which is a 5mm scope, we use a pediatric one, which is 3.8 millimeters. And again, we learned this from intubating ourselves. We like a 6.0 tube in our nose, not a 8.0 tube. And we like a 3.8 millimeter scope goes through that 6mm tube very nicely. A 5mm scope is a little tight and creates some pressure.
Can I make just a quick point about that? Because, that 6 versus 8 is a really big deal, because a lot of people who learn to intubate think there's some machismo or some greater degree of success the bigger the tube they put in. These are life-saving airways. They're not meant to be airways that you wean a person off of a ventilator weeks from now that has COPD. It's an immediate life-saving airway, right? So you want to have a narrow, small tube.
Yeah, and as tubes get smaller in diameter, they also get shorter. So if you're going to use a 6.0 tube on a big, tall adult and go through the nose, you might want to order a specialized one, which is what we do. We use microlaryngeal tubes, which are 35 centimeters long, and they come in 4.0, 5.0 and 6.0. Those are only 3 sizes. So we use the 6.0 one. So you can't do this in everybody. You're not going to be doing it in a guy like this, whose face is all smashed up. It's just, if you add blood and other injuries in, people that need to be, who can't sit up straight and cooperate, it's not going to work.
But that's why you have multiple approaches, right? If the only training you do is like everything I do is hyperangulated video, you're going to run into a problem, right? And that's why you have to not only have your backup airways out and obviously do all the things to prep people appropriately, you have to have different options.
Yeah, before you start this, you want all your stuff ready in case it doesn't work. In case, people say, well, I'm going to get in the middle of this and they're going to get laryngospasm or something. First of all, laryngospasm doesn't happen if the cords have lidocaine sprayed on them. That's the solution to that problem, really, is to spray lidocaine on the cords if you get laryngospasm. So we're going to be doing that right up front, so that's not going to happen. But people can freak out and get, if someone has a really narrow airway, they might get very anxious and start freaking out, and that might make them decompensate. So you need to have all your stuff ready. You need to decide if you're going to go nasal or oral. Nasal is easier, and we know that because we, again, practice on ourselves. It's technically easier. It might be a little more painful, but if you do it right, it's just some pressure, really, not pain. And then, like I said, most people call this awake intubation, but yet they sedate the patient. Try to avoid sedation altogether. If you're going to give any sedation, don't give ketamine. It's the worst thing because it's very unreliable. Patient might get cooperative. They might start screaming. They probably won't be able to follow commands anymore. And so if you're going to give anything, a little bit of Versed, a very little bit of Versed.
And I think that's an important thing to emphasize. So definitely you can dissociate people in things with ketamine, and a lot of people talk about ketamine because you preserve the airway reflexes. But in something like this, if they're well topicalized, maybe a little bit of anxiolysis, maybe, and most of the time not even. Once you start practicing on yourself, you'll be amazed at what you can do without any sedative.
Well, you may not want to preserve the airway reflexes. And is there any truth to the ketamine and then touching things precipitate laryngospasm?
You can definitely get laryngospasm with ketamine, but I think it's from secretions dripping onto your vocal cords and just a response to
So
that.
bottom line, don't use ketamine.
I would not use ketamine for this. So, okay, if we're going to go through the nose, like I said, it's technically easier because if you stick something up someone's nose, it has a straight shot down into their lungs, and there's no curve. The curve that you're making is up in the nasal passages, not down right at the cords, like if you go orally. It's better tolerated in most fully awake patients. People don't like stuff right on their tongue, generally. The oral approach, some people tolerate this very well. We've done it in courses where we were teaching doctors how to do this, and we've intubated them orally, and it does work. You just have to really, instead of snorting the lidocaine ointment, you put it on the back of the tongue if you're going to go orally. And we'll show you what that means. It helps to go through an oral airway that's made to intubate through, which is a Williams, a Berman, or a Ovasapien. We like the Williams just because it's the easiest. It's like covers all sides of the tube. So we'll show you pictures of that. This can be easy to learn with practice, though, too. The reason you want to keep someone totally awake is so you don't have them so sedate that they can't cooperate or follow commands, or people with tenuous airways, you just like to keep them awake so they can keep their airway open. Like I said, most providers don't do this. Most anesthesiologists who do endoscopic intubation they like remifentanil, I've heard. Sounds nice, but we don't have that. But I would use a little Versed if I'm going to use anything. But again, try not to use anything, and your topical skills would be much better. So here's a secret recipe that we came up with. This is just our airway checklist. Get all the stuff ready before you start. So the recipe this is not a critical part of it. This is glycopyrrolate is often suggested to be given to dry up the mucous membranes before you start. I probably skip this most of the time, and it doesn't seem to matter. And when we do this on each other, we don't do this, and it works fine. So that's the least critical step. Afrin is critical if you're going to go up the nose. You don't want to create a nosebleed, especially when you do this on yourself and your friends. And then the next thing is the lidocaine ointment. So a 5-gram tube of 4% lidocaine ointment, not gel. Gel does not work. It just quickly leaves the mucous membrane. This stuff sticks to the mucous membrane. You'll see in some of the video we're going to show you that it's all over the place during the intubation. It does get in the way a little bit, but it's the key to really a topical anesthesia, especially in the nasal passages. After we put that whole tube we have the patient snort that whole tube of lidocaine ointment, 5 grams, after about 5 or 10 minutes, let it sit up there. And then this is a critical part. If you're going to stick a 6O tube up someone's nose, make sure there's enough room first. And the way that I do that is with my little finger. I take my little finger and I push it all the way up their nose, not all at once, but slowly push it up there. And you'll actually feel, even people that have almost no room, if you put steady pressure into their nasal cavity, it'll just dilate up, and sooner or later you have your whole finger in.
And that's the key. You got to slowly. You got pressure, just gradually advance.
Yep. And so you can see this is one of our prior residents and fellows, and she was like, "This isn't going to work," and it ended up working fine.
You're doing it along the floor of the nasal cavity.
Yeah, you're going along the floor of the nasal cavity and just steady pressure, not too hard, and just kind of like you'll feel it open up.
Almost horizontal to where that picture is.
Yeah, and you'll hear people say that you can put a nasal trumpet in and do the same thing. That's absolutely not true. The nasal trumpet doesn't. It's rubber. It squishes down. It does not. It's not as firm as your finger, and it's not going to dilate up. If you use a nasal trumpet, then when you stick the 6O tube up there, half the time you'll get a very bloody tube. So do this, and it'll work. The next thing you do is we take an atomizer. We do not use nebulized lidocaine because nebulized anything goes down into the lungs. It doesn't go on the upper airway where you want it, and it just doesn't work. So use an atomizer. This is just a magic atomizer. It's like a couple dollars each, and it's malleable. You can bend it whatever shape. And what I do is I take 10 mils of 4% aqueous lidocaine, and I fill up that whole 10 mil syringe. And then based on the size of the patient, if it's a big patient over 200 pounds, I can use that whole syringe. And that's after they got the 5 grams of lidocaine ointment. The reason they can get that much is this has been well studied. You can get up to 9 milligrams per kilogram, which is way higher than the previously described doses of lidocaine. And the reason for that is because if you spray this down into the patient's lungs, which we're not doing, a little bit of it's going to go down through the cords, but most of it's going to go above the cords and be swallowed in the GI tract, and only about 30% of that gets absorbed centrally. If you spray all that down into the lungs, 100% gets absorbed centrally very quickly. So unless you empty that whole thing down through the cords into the lungs, which is not the point, you're not going to have problems with toxicity. Generally, my general approach is I try to stick to 5 mils of the aqueous for a very small patient, like 100 pounds. And I'm okay using the whole 10 mils in a 200 pound or more patient.
So Rob, is this a spray out the end, or is this a radial spray?
Just sprays right out the end, right at what?
Like a cone shape, right?
Yeah.
Yeah, misting.
You'd like to be like a centimeter from what you're spraying. So I try to go around the tongue, try not to touch the tongue, go around the tongue and point it right at the cords and move it back and forth as you spray. I just do 1 mil and then I take a break, give the patient about a minute. I do 1 more milliliter. And now only 2 millimeters are gone out of that syringe. And then I take the rest of the syringe and I put it on the bronchoscope so I can spray it as I go through when I'm hovering above the cords of the bronchoscope. I'll spray the cords 1 more time or maybe 2 more times. In most people, you only need like maybe 4 to 5 mils. You don't need the whole 10, but it's nice to have it in case you get down there with the bronchoscope and they're coughing and coughing. If they're coughing, they're not prepped properly. So then the next thing we do, we've got the lidocaine ointment there. We got the aqueous lidocaine sprayed on the cords at least twice. We're going to take the tube, put it in the nose, the 6.0 tube. We're going to put it into, lube it up, warm it up, especially when you're doing it on yourself. You'll appreciate it being warm because it's softer. Now, then just push it back along the floor of the nasal cavity to about 12 to 14 centimeters. And when you're doing it on yourself, you'll feel it's in the back of the nasal cavity and you'll feel pressure, and then it'll all of a sudden give, and that's when you stop. So you want it to make the corner, like when you're putting an NG tube in, make the corner and be pointing toward the cords, then stop. Now you drive your scope in, and when you come out, ideally you come out the end of the tube, you're looking right at the cords. And here's an example of putting the tube in. It's the worst part when you do it on yourself. If you warm it up, it's nicer. The nice thing about the microlaryngeal tubes that we have is they're a Parker Flex tip, so that the tip is nice and soft, and even softer if you heat it up. So this is me just putting the tube in her nose. Now we have the tube into about 12 to 14 centimeters, and you can see when he's going to drive out the end of the tube, and there's her. You can see her epiglottis and stuff right away.
Very little distress on her face.
Yeah, if you're properly prepped, you can't feel any of this at this point. The thing that you feel is when the tube goes around the corner in the back of your nasopharynx. But this you shouldn't be able to feel at all.
When you're first starting to do this on each other, a lot of times we have the person who is getting the scope advance the tube themselves, just so they can feel from the inside and out.
So you see here, he has now they're all done. Let's go back there. So he has the on the end of the scope, there's a port. And if you have a slip tip syringe, or there's an adapter you can put on there too that comes with the bronchoscope. But the syringe of the extra aqueous lidocaine that we didn't spray through the atomizer is now on the end here. So when he gets right about a centimeter above the cords, they're going to spray a little bit more right on the cords. If she coughs a lot, she's not prepped, then you want to wait another minute, spray another mil, and usually after 1 or 2, they'll stop coughing. You want some of it to go down in the lungs, and it's okay to have the person inhale while you do that, while you push that. But you would definitely want to spray a little bit from right above the cords before you go down to make sure they're properly prepped.
And other things, the scope is nice and taut, nice and long, right? Facing the patient. I mean, you have all your control right there.
Yeah, so he's holding the scope, and the way he's going to control it is with that little thumb lever, and then rotate the scope, and that's about all there is to it. But it's a lot easier to do if you're facing the patient like this, and they're just sitting up following commands.
Yeah, you want to take advantage of the natural curve of the scope. You don't want to be above the head if they're lying down, for example.
Yeah. Generally want to wear gloves, though. So you can see that was not so distressing. Okay. This is me just doing this quickly. This was in one of our courses. We're teaching either our residents or our faculty, but I'm all prepped up, and you can see how quick. This part's not so quick, but if you can just stand there in a room and do this on yourself, it's not hard to learn, right? So you can see it's an extra long tube.
So you've done the 4% lidocaine, the Afrin.
Yeah. Now it's just made the corner up in my nasopharynx, and you're going to see him drive through it. There's my art there on the board. You can see him drive through it, and when he comes out the end, you'll see the tube's in a great spot. There's some of the lidocaine ointment, which kind of gets in the way. So when you come out the end, the way to clear off the scope is to have the patient swallow. There you go, right above the cords. And then you're going to see someone reach over here and spray the lidocaine. He's about a centimeter above the cords now, and they're going to spray lidocaine right on the cords. You can see I didn't cough very much. So he's ready to go through. And then you can see, and I can't feel this at all. He just drives down. And you can always spray more lidocaine right there too, down into the trachea. That's probably a good idea to spray more, half a mil or a mil down there. But you just drive down pretty close to the carina and then just push the tube in.
In getting that tube in first, before you put the scope in, people do it other way. Sometimes they'll have the tube up on the scope, but one of the hardest parts is getting that scope around the corner, or getting the tube around the corner. And once you're there, then putting the scope through it and then advancing it down. And usually, most of the time, you'll be right above the cords. Pretty easy.
Yeah, and when we do this on ourselves or our coworkers, we let the person who is intubated be the one to control the balloon there, so they don't freak out and pull it out with the balloon. So this is what it looks like normally when you come out the end. So there's nothing interesting inside the tube. Just go through fast. And then when you come out, you should be looking right at the cords.
Post-intubation.
If you get goober, no, this is just another intubation. Close up. There you go. You come out right above the cords. And remember, you're not, if you've decided to intubate the person, this is not a diagnostic scope. If it's really swollen in there and you don't recognize anything, and the first thing you see is that you're inside the trachea, don't pull it back and make it a diagnostic scope. Just push it down to the carina, push the tube over it, and you're done. Okay, so when it's really swollen, that's when you have trouble with this. There's all our faculty intubated. So the oral approach, we'll just do this really quickly because we usually go through the nose. We put the lidocaine ointment on the tongue with a tongue depressor on the back side of the tongue, as far back as you can get. And I actually tell patients, all your life you've been trying not to aspirate. Go ahead and let yourself aspirate right now. And basically trying to tell them, just hold your mouth open and don't swallow. And after a few minutes of that lidocaine ointment just melting, when it gets to body temperature, it'll just drip down around the vocal cords and give them great topical anesthesia. And for people with a strong gag, that's the way to go, because that'll eliminate their gag. And then after that, I spray the same area with aqueous, 4% aqueous with the atomizer. So kind of double prep of the back of the tongue and the cords. Same thing we do with the the oral approach or the nasal approach. And then we take the Williams airway, which is one of these, and these are the other choices, but we like the Williams better. What I do is I load the tube and the scope into the Williams airway, just like this, till the tube is at the end, the scope's sticking out a little bit, and then I have someone else drive the scope, and I place this right in the midline on the tongue, and I bring them, I'm watching the screen along with the person with the bronchoscope, and then I bring it right to the cords. So you can basically just almost intubate the person with this device. And then just as soon as you get above the cords, maybe spray one more time with some lidocaine, and then just all the person driving the bronchoscope has to do is push it forward a couple centimeters, push it down to the carina, and you're done. So it's really, the important thing is the person holding this in the midline. You really want to hold this whole thing in the midline and hold it here so that the tube's not sliding and the scope isn't inadvertently sliding forward or backward. But that approach works really good. That's really quick. Then you don't have to drive the scope around the tongue. The Williams does it for you. We said all this, avoid ketamine. One thing you should know is that I have RSI meds ready, and I ask an assistant on each side of the patient to hold their arms down toward the end of the procedure, because for most patients, when they feel that there's something in their trachea, they can feel kind of resistance to breathing. Then some of them will just inadvertently, without thinking about it, reach up and grab the tube. And you don't want that to happen once you've already done with the procedure. So hold their arms down, quickly give them a sedative. We usually have we always have RSI drugs pulled up just in case something goes wrong. So we just usually give those right when we're done. All right, in summary, this is an easy procedure. It absolutely requires practice, though, and really the only practical way to practice is you can practice on a mannequin, but you're not, like we said, 90% of the procedure is a topical anesthesia, and that if you're practicing on a mannequin, you're just practicing the scope part of it, which is the easy part, right? So practice topicalizing yourself or your friends, and then stick something up your nose and see if it hurts or not. And if it doesn't, you did it right.
So the only thing I would add is, as you begin to learn this, learn it from people who do it. For example, in our institution, an anesthesiologist would never see that second slide guy with his face smashed. Now that's not going to get an endoscopic intubation, but it's a difficult airway. That guy gets to the operating room with his airway established in some other means. The point is you guys in the ER do this. That's where you should learn this.
Yeah, and if somebody thinks that they have a better procedure that works better than what we just showed you, I challenge them to try it on themselves and see what it feels like, because I guarantee you won't want it done on yourself. If you don't do this exact procedure, you're going to be either bleeding or in terrible pain, and you're probably not going to end up getting intubated. Yeah.
In any airway procedure, the place to learn emergency airway management is from people who do it all the time. And you have to have multiple techniques available. There are a lot of places that we all get trained and maybe did some innovations in the OR, but really learning from people who do this all the time. A lot of being successful with airway management is the preparation, having the right equipment out, having patient position, the pre-oxygenation, all those things that we talk about, and then having multiple options. Every airway is unique. Always have to have your backup airways, but really the best way to learn about this is to come and get trained by people who do it all the time. And certainly our airway course, I think, is a great opportunity where we introduce all of these things: fiberoptic, awake, intubation, ILMA, and video laryngoscopy, bougie guided. And really, Anapin has the highest success rate across the country. 98% first pass success.
Yeah. Yeah, and that's what RSIs. This just kind of adds to it. I mean, if you know how to do this and you're really good at RSIs and you have an LMA and you know how to do a crike, you're not nervous when you go to work anymore, because you really have all those options. So this is something that we don't use very much, but when you need it, you really need it, and it's really nice to have it available.
And for those people, I talk to people, sometimes they get difficult airways. I'm like, well, I only use the bougie on the difficult airways. Is that the time you think you should pull out a tool that you don't use very often on the really hard ones?
Yeah. Our theory is do everything the same every time, whether it's easy or hard, and then you're used to handling the equipment. So no, you want to do it
And there's no downside. There's no downside to using a bougie on what you believe is going to be the simple airway. And we all know who do airways. There are many times you completely misjudge what looks like a completely easy airway externally, and you get in there and there's trouble.
And I would say someone who tells you they're only using the bougie on the difficult airways, I would run. I would go learn from someone else, because that is clearly not someone who's probably an expert in airway management. And I think you follow the numbers and you go where it's been successful. And that's essentially what we do. We just copy all the stuff that is done in some of these places, and it works out reasonably well.
Yeah, and when we teach our airway course a couple times a year, we'll intubate at least one person wide awake. Sometimes it's a volunteer, one of our faculty, but if someone comes to the course and really wants that experience, we can line it up. Learning on yourself, once you do it once, you never forget how to do it, right?
Good. Well, my only question is how'd you get so tall?
If you had enjoyed our topics and want to learn from us in person, visit our website at hqmeded.com and discover our exceptional courses. Let's elevate patient care together.